All right, yeah. So in terms of the management and therapy for the dry eye disease, what the dues to aimed was provide the guidelines as to how to achieve the homeostasis of the tear film and alleviate the ocular discomfort. Also, determination of the cause of dry eye disease is critical for selecting the most appropriate management strategy. And Bhaskar just now explained how do you do the investigations to delineate those things. Also, we should remember meibomian gland dysfunction is a major contributor to both the signs and symptoms of the dry eye. And failure to resolve the signs and symptoms of dry eye may relate to deficiency on underlying disease. So for me, when I see a dry eye patient, I just don't label it as dry eye. First look at whether there is a local or a systemic disease which is accounting for the symptoms. Like for example, if you have OCP, SJS, other cicatrizing conjunctivitis, VKC, AKC, rheumatoid arthritis, Sjogren syndrome, or any local factors. So Dues to proposed a 4-stage management algorithm that presented the stepwise approach for the management. And I will now talk to you about those management strategies. So this is essentially treatment for tear insufficiency, treatment of lid abnormalities, surgical approaches, dietary modification, if any, and anti-inflammatory therapy. The tear insufficiency you can address by tear replacement, tear conservation, or tear stimulation. Most frequently, all of us use is the tear replacement, which can be artificial tears, lubricant, biological supplements, or like autologous serum. And more infrequently, we do use punctal occlusion or moist chamber spectacles. Rarely we use topical secretagogues or oral secretagogues or nasal neurostimulation. Artificial tears, they are the mainstay for the dry eye therapy, and they attempt to replace or supplement the deficient tear natural film. Here we must understand that we are talking about a dry eye disease which is not associated with anything topical or a systemic or local disease. In that, we need to have a tear replacement strategy. In other diseases, it's only an adjunct to the main treatment. They are typically buffered solutions that contain electrolytes, surfactants, or one or more viscosity agents or lubricants. These products do not target the underlying pathophysiology of the disease, but they alleviate the symptoms. And also remember that there are very few or hardly any RCTs, randomized controlled trial, to compare the efficacy of the superiority of one agent versus the other in terms of the products. So we should remember that very important point. Then what are these ingredients of these? They are viscosity enhancing agents like CMC, HA or CMC plus HA, variety of combination, osmotic agents, osmoprotectants, lipid supplements, preservatives, inactives like excipients, electrolytes, and then antioxidants. All the tear supplements what we have drops are a combination of one or many of these components. Osmotic agents, as we know, the hyperosmolarity is a common denominator for the dry eye disease, and it initiates a cascade of inflammation. So therefore, it's very obvious to use or correct the osmotic imbalance. So use of hypotonic, hyaluronic-based ocular lubricants have shown the improvement both in sign and symptoms of dry eye disease. Some studies have shown that dry eye treatments have the potential to improve the tear osmolarity in absence of any clinical improvement or clinical feature improvements. Others, like use of topical cyclosporin, osmoprotective drops, or other things, may change the osmolarity as well as improve the sign and symptoms of the disease. Osmoprotectants are a group of compatible solutes that protect the cells under extreme osmotic stress, and they balance out the osmotic pressure in the extracellular as well as the intracellular environment, therefore preventing the disruption of the cell metabolism. And they have been shown to be effective, at least in vitro studies, like in cultured human corneal epithelial cells, inflammatory suppressing properties, or they reduce corneal staining, decrease cell apoptosis, and reduce anti-inflammatory cytokines. There are some drops or some companies are incorporating lipid-containing artificial tears, and they are generally formulated as emulsions. They help to restore the lipid layer of the tear film, so used in the management of MGD and lipid deficiency. And these products are Systane Balance and Systane Complete. I'm not sure how much of them are available in the Indian market. Phospholipids commonly found in the human tear films are phosphatidyl choline, and the other, which is very long name, so I won't say it. Systane Balance. It was easier to say that in biochemistry class, but now it's very difficult. It's like a tongue twister. So Systane Balance tear contains a polar phospholipid, which can potentially restore the lipid layer of the tear film and improve the signs and symptoms of the lipid deficient dry eye disease. And the other one is more of a nanoemulsion and contains nanoparticles of the phospholipid, higher content of other ingredients, and therefore provide a more balanced formulation. Then we focus on the lid abnormalities. So it's very important to pay attention to blepharitis and MGD. Blepharitis you would treat with lid wipes, scrubs, or hot fermentation, topical antibiotics, which may be used to reduce the bacterial overload. And in case of Demodex, Demodex infestation is quite common, especially I'm seeing more cases here in North India. And so using tree tea oil is very, very useful. And then in MGD, the lipid-based lubricants, warm compresses, and physical treatments like forced expression. And now we have good devices in the Indian market. There are some masks like Evolve. There are some other lipid compression treatments which you can provide in the office. And also pay attention to the blinking abnormalities. Some people don't blink enough, especially when they're doing work which needs attention. Anti-inflammatory therapy would be topical steroids, primarily the surface active steroids, non-glucocorticoid immunomodulators like cyclosporin A and tacrolimus. Then inflammatory modulation with systemic and topical antibiotic like tetracycline and other macrolide like azathioprine. But NSAID, I'm not sure that I generally don't use, but this is something is included in the guidelines. Then there are some biologics like lubricin, which is shown to be effective in the laboratory studies, recombinant nerve growth factor, and variety of other such factors like exosome-based treatment. There is a company in America now which has launched a exosome-based eye drops for the ocular surface regeneration and to reduce the inflammation. Inflammation modulation with systemic and topical antibiotics. When needed, we may have to do tarsorrhaphy for conjunctivochlesis, specifically if the immune or anti-inflammatory therapy does not reduce the symptoms, then you may have to do a resection of the redundant conjunctiva. And also in cases of blepharospasm, you may have to treat with injection of botulinum toxin, lid corrections like dermatoclesis, blepharoptosis, etc. And then the major or minor salivary gland transplantation. Those things are very rarely used, I must say. Then this is the management algorithm, which we talked all the things, triaging questions, risk factor analysis, and diagnostic test. And then there are step 1, 2, 3, 4. These steps are not like mutually exclusive that you will do only step 1 first and then go to second. No. In a given patient, you may have to do all of them depending on the condition, depending on the stage of the disease. So the first step talks about primarily educating the patient about the condition, management, prognosis, and what are the modifiable local environmental factors, like in case of computer vision syndrome. In case of a patient who is a lady who is a perimenopausal phase, so telling them about dry eye is not sufficient. You must tell that this is a part of the hormonal changes in the body. And this happens in men as well. Education regarding potential dietary modifications. Identification and potential modification or elimination of offending systemic or topical medication. Ocular lubricants of various types. And lid hygiene and warm stresses depending on the condition. Step 2, if the treatment given in step 1 is not adequate or the patient does not feel the symptoms are not improved, then consider non-preserved ocular lubricants to minimize preservative-induced toxicity, treat oil for Demodex infestation if any, and then other factors like tear conservation, overnight treatments. I typically use ointment at night in moderate to severe dry eyes. And you can also consider the in-office treatments, the LipiFlow and other things if you have other these devices. And a short course of topical steroid or antibiotic. I prefer only steroids in most situations. I give as a pulse dose. Pulse dose means that you give for 6 to 8 weeks and then you stop. And if the benefit is there and the dry eye symptoms decrease, then add on cyclosporin or tacrolimus. So 3 would be if the treatment given in step 2 are inadequate, then consider oral secretagogues, which I really don't have any experience of using them. Autologous or allogenic serum eye drops, yes, I have used quite a lot. Therapeutic contact lenses, especially I use Prozlens for last 15, 18 years. This is also called liquid bandage. They're very helpful in extreme situations. And then the step 4 is topical steroids for a longer duration. Amniotic membrane grafts. Amniotic membrane is not done for dry eye. It is done for specific indication like conjunctivitis. Similarly, surgical punctal occlusion like punctal cautery in patients with severe Stevens-Johnson and other approaches depending on the situation. So, in summary, the various strategies are available for management of dry eye, and we have now in India so many, all the options which are available in the global market are available in Indian market. So, it's a very good news for all of us. The tear film products are so many, choosing them which one for which indication is a very confusing situation. But that's something clinicians need to define their own sort of algorithms. So therefore, DEWS2 report proposed this 4-stage management algorithm that presents a stepwise approach for implementing and management and therapeutic options. Recommendation in the management algorithm may be modified or overlap as required by the clinician based on their local or individual choices and patient preferences. Thank you very much.